Our last liver section, we're going to talk about hepatic encephalopathy and Reye syndrome. We'll go back to our liver physiology and a little bit of our liver cirrhosis lecture during this because I talked about hepatic encephalopathy there for briefly. So in our physiology section, I mentioned that ammonia is a potentially toxic byproduct of digestion. And how we remedy this problem is that we can actually convert ammonia to urea in our liver, and then that urea can get safely excreted in our kidneys. So if we have ammonia, it'll go through the liver and get converted to urea, and everybody's happy. What happens though, if you have a defective liver, let's say you have liver cirrhosis, what's going to happen is that this process won't work as well, and you might get a buildup of ammonia in your blood. And if you have a buildup of ammonia in your blood, it can lead to a condition known as hepatic encephalopathy. So hepatic encephalopathy is caused by decreased ammonia metabolism. And all that ammonia in your bloodstream can lead to neurologic dysfunction. This will present, as the name suggests, with encephalopathy or altered mental status. You'll also see something called asterixis. And what does asterixis looks like? You're going to have your patient put their arms out and point their fingers to the ceiling while keeping their arms spread out in front of them. And if you push, you can either push back on their arm, or sometimes you don't even have to do anything. If you just have them, stretch their arms out straight ahead with their fingers pointing the ceiling, you'll notice that their arms, their hands, and their wrists especially start doing this flapping tremor. So it'll start to do this flapping tremor like this. And that's indicative of, that's a physical exam maneuver that you can do to increase your clinical suspicion for hepatic encephalopathy. And this can get very severe. It's not like it just causes altered mental status. If you have severe hepatic encephalopathy, it can lead to coma or even death. So there's a few different things that can cause hepatic encephalopathy, most of which are related to liver cirrhosis. We just talked about why liver cirrhosis would cause that buildup. You can also have people who have some sort of baseline cirrhosis, but they're able to metabolize ammonia at some steady state. But if they have an acute GI bleed where additional ammonia is being released, or if they have an infection where the bacteria is releasing ammonia, or they have renal failure, all of these types of conditions can increase the amount of ammonia in your bloodstream and cause a problem. So in renal failure, what's happening here is that normally that urea gets excreted in the kidneys, but if your kidneys aren't working, you can get a buildup of urea, and that can actually backflow and cause a buildup of ammonia as well. One thing I want to mention, and we talked about this earlier, is that a TIPS procedure, which is often used, not often, but is occasionally used to treat significant portal hypertension, ascites, varices, things of that nature, a TIPS procedure can ultimately precipitate hepatic encephalopathy. So what's happening here is that if we have a lot of ammonia, normally it's going to go through our liver and be converted into urea, as we've talked about. In a TIPS procedure, which is done to alleviate portal hypertension here, what will happen is that this portal fluid can now drain directly into our hepatic vein, which will alleviate our portal hypertension and congestion. So that sounds great, but the problem with that is that now all this ammonia is also bypassing the liver and going straight into our hepatic vein. So instead of being converted into urea for excretion, we now have excess ammonia in our system, which can precipitate hepatic encephalopathy. There's two treatments I want you to know for hepatic encephalopathy, and those are lactulose and rifaximin. And I'm going to go over the mechanisms now. So lactulose, for lactulose, I want you to, we're going to talk a little bit about acids and bases. So ammonia, NH3 is a base. And what is a base versus an acid? So back to basics. So an acid is anything that can basically get rid of its hydrogen ion, and a base is anything that can accept the hydrogen ion. So there you go. Acids donate protons and bases accept them. And you can remember this by just remembering that that hydrogen ion always moves from point A which is your acid, to point B, your base. So here we have an acid, it gives off its hydrogen, and in the case of ammonia, ammonia can grab that hydrogen and turn into ammonium. So it grabbed that proton, and now it's got a positive charge on it, as you can see. So in the case of ammonia versus ammonium, what I want you to realize is that this NH3, the ammonia form, can easily cross our GI tract barrier and enter our bloodstream. But this NH4 positive ammonium cation cannot easily cross our GI tract barrier because of this positive charge. So how do we use this physiologic discrepancy to benefit us in a patient with hepatic encephalopathy? Well, what we can do is we can give somebody lactulose, and lactulose will break down to a lot of lactic acids. And those acids naturally will release a ton of protons, and ammonia will see all those protons that are being released, and it'll start binding to them because it's a base. It'll bind to those proteins and create a bunch of ammonium cations. And fortunately for us, these ammonium cations cannot be absorbed by our GI tract, and they'll instead be excreted. So in this way, we're helping with our hepatic encephalopathy by not allowing any new ammonia into our system. Rifaximin works in a little bit of a different way. So rifaximin is an antibiotic, and normally we have bacteria in our GI tract that can produce ammonia. So here's our GI tract bugs, and they're producing ammonia, which can ultimately be absorbed into our bloodstream. Rifaximin is an antibiotic that can help kill some of these bacteria that are producing all that ammonia. So if we have rifaximin coming in, it'll take out some of those bacteria, which will ultimately decrease our ammonia in our GI tract and our bloodstream. Now let's change gears a little bit and talk about what Reye syndrome is. So Reye syndrome is hepatic encephalopathy that occurs in childhood. And if you think about all the causes of hepatic encephalopathy that we talked about liver cirrhosis, we talked about GI bleeds, TIPS procedure, really significant infections. Most of those don't happen in childhood. So the reason why a child would have hepatic encephalopathy is through aspirin consumption. So what happens here is a child will consume aspirin, and that'll actually cause damage to the mitochondria inside the hepatocytes. And so if we go back to our liver lobules and zones that we saw in our liver anatomy section, I mentioned that zone 3 has the highest mitochondrial content. And in the case of Reye syndrome, what's happening here is that this aspirin will interact with these mitochondria in the hepatocytes, and it'll start to kill off this zone that can damage the entire hepatocyte and result in Reye syndrome or acute hepatic encephalopathy. So you might get nausea and vomiting. They can go into a coma, and it can lead to death. Because again, if you have this acute liver failure, essentially, where all of your hepatocytes are dying, then all that ammonia that's supposed to be converted to urea will just stay as ammonia, and it'll flow through your bloodstream, and it can cause, like I said, it can cause coma and death even. On histology, you're going to find microvesicular fatty changes. There's been a few lectures now, maybe not a few lectures, there's been a few liver conditions that we talked about earlier that caused macrovesicular changes. So this is the first time I'm going to mention microvesicular changes. So these are changes where you'll notice small vesicles inside of hepatocytes. And if we take one of these cells here, you can notice how there's several small vesicles. I'll remove this circle so you can see all those mini circles inside of there. Those are small vesicles inside of each hepatocyte. Notice that these vesicles do not distort the nucleus. You can see the nucleus in the center of the cell still. And here's a couple other cells I've highlighted where the nucleus hasn't been pushed to the side of the cell. It's still comfortably in the middle of the cell. And my mnemonic for remembering that Reye syndrome causes microvesicular changes is that Reye syndrome itself is a childhood disorder. So it's kind of a disorder that would happen when you're a micro person. We'll contrast that with our macrovesicular changes that I discussed earlier. And in macrovesicular changes, you're going to have one large fat globule, one large vesicle. We don't get any more of those microvesicular changes in this case. You can actually see microvesicular changes here. This is a good slide because it shows microvesicular changes here, these little mini circles. But in macrovesicular changes, you're going to mostly have these predominant fat globules. And what these globules will do is they end up pushing the nucleus to the side of the cell. You can't even see the nucleus inside the cell. And you'll see these in more adult conditions, fatty liver disease, alcoholic liver disease, some forms of viral hepatitis. And I remember that by thinking that these changes happen when you are, a macro person, you're an adult, and so you'll see these macrovesicular changes. One thing before I end on Reye syndrome specifically is that you always want to avoid aspirin consumption in childhood, other than the condition Kawasaki disease. The reason why we give aspirin in Kawasaki disease is we basically accept that there is a risk of Reye syndrome, but we also know that Kawasaki disease is such a dangerous inflammatory disorder that can basically cause sudden death with cardiac coronary aneurysms. So it's one of those rare conditions where we give aspirin knowing that it has a risk of Reye syndrome, only because aspirin is so effective in treating Kawasaki syndrome, or Kawasaki disease, I should say. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.